Hello there. Good afternoon, and welcome to the podcast. My name's Eric Drago. I'm a third-year medical student at the Commonwealth Medical College and one of the instructors for the IGL sessions. Today I want to record a podcast that I'm calling The Kidney, a Basic Science Overview. So like a lot of these podcasts, I want to begin by going over some learning objectives and just kind of lay out a couple of things that I hope to accomplish as we go through this brief podcast. I want to get across and hope that you understand the basic anatomy of the kidney. Hope that you gain an appreciation for the nephron and its role in filtration, and that you understand the structure and function of the glomeruli. And finally, I want to get across some of the importance of the kidney in the regulation of blood pressure, calcium, and hematopoiesis. Alright, the kidney. The kidneys are a paired organ system that serve many functions. Chiefly, the kidneys filter and excrete metabolic waste. They regulate electrolytes, fluid, as well as the acid-base balance, and are crucial in the stimulation of red blood cell proliferation. The kidneys also serve to regulate blood pressure through the renin-angiotensin-aldosterone system, and they serve an important role in increasing the intestinal calcium uptake. We're going to touch on many of these topics in our overview, but we're not going to really delve too deep into any one subject in particular. We'll save that for your upcoming courses. So this first slide here, I just want to kind of get across that the kidney really and truly does look like the appropriately named kidney bean. Even the color of the kidney bean is similar to the gross human kidney. Of course, it's just much, much smaller. And on the right here, a little bit of basic picture that's just the anatomy of the kidney, and it highlights some of the structures that we're going to talk about as we move forward. So to begin, the gross anatomy of the kidney. The kidneys are paired retroperitoneal organs. So in other words, they sit behind the peritoneum. They are located within the human body between T12 and the L3 vertebra. The right kidney is situated just below the diaphragm and posterior to the liver, while the left sits below the diaphragm, and behind the spleen. Due to its proximity to the liver, the right kidney is slightly lower in position than the left and is often a bit smaller, although there is a lot of anatomical variation, so this isn't really a hard and fast rule. Atop each kidney sits the adrenal gland. Around each kidney are two different layers of fat, and these adipose layers, as well as the dense renal capsule, provide some degree of protection from blunt trauma and damage. And if you're fortunate enough to get into a gross anatomy lab in the future, the dissection to get to the kidney was actually very, very interesting, and there's much more fat than you would imagine. Okay, so moving on from the kind of gross anatomy, let's just dive in a little bit further and talk about the structure of the kidney. So the kidney can be divided into two major structures, the outer renal cortex and the inner renal medulla. Within the renal medulla are the renal pyramids. As you can see, they kind of look like an inverted pyramid. The renal pyramids are comprised of the nephrons and the collecting ducts. The tip of each renal pyramid, or papilla, enters into a minor calyx, into a major calyx, and then finally into the renal pelvis, where it's collected in the ureter and eventually makes its way to the urinary bladder. And this is a pretty good image. It's not too busy, so you can really follow, if you look on the right here, the path of the urine as it drains from the nephron, again to the collecting duct, papillary duct, minor calyx to major calyx, renal pelvis, ureter, and then finally into the renal bladder. Moving forward, let's talk a little bit about the vasculature of the kidney. So directly off of the abdominal aorta is a pair of arteries that are the renal arteries that supply blood directly to the kidney. The renal artery, as you can see in this image on the right, further branches into the segmental artery, an interlobal artery, an arcuate artery, a cortical radiate artery, and then at this point, inside this little dashed box here, are the nephron-associated blood vessels. So the blood which originated in the aorta makes its way to the afferent arteriole, through the glomerulus, through the efferent arteriole, and then through a series of veins that eventually make their way all the way back to the inferior vena cava. The afferent and afferent arteriole are two very important structures, And good way to remember which comes first in this scheme is that A comes before E in the alphabet, and A, of course, is the first letter in the alphabet. So I always think afferent arterial must be first, followed by efferent arterial. And then to further reinforce that, the efferent arterial starts with E, like exit, so I think that efferent arterial is where the blood exits the nephron. Okay, so now I've mentioned the nephron a few times, but I haven't really defined it. So what is the nephron? The nephron is the basic structural and functional unit of the kidney. Each kidney contains between 800,000 and 1.5 million nephrons. The nephron itself contains a renal corpuscle, the renal corpuscle, which is comprised of the glomerulus and Bowman's capsule. So if you follow this image where I have the pointer, you go from Bowman's capsule to the proximal convoluted tubule, and then down the descending loop of Henle, up the ascending loop of Henle, to the thick ascending limb, through the distal convoluted tubule, and then finally into the collecting ducts, which will then get us back all the way eventually to the ureter and into the urinary bladder. And this is another pretty good image that kind of highlights everything that we've talked to, and again can show the efferent arterial where the blood exits and the afferent arterial where it enters. Okay, so now that we've talked about the nephron and one of the most important components of the nephron being the glomerulus. The glomerulus itself is a tuft of capillaries located at the beginning of the nephron. So this whole structure here on our left. It is the first stage in filtering blood and the production of urine. The glomerulus itself is surrounded by Bowman's capsule, and this capsule receives the filtrate and then empties into the proximal convoluted tubule and then down to further structures that we talked about in the previous slide. As mentioned earlier, the glomerulus receives its blood supply from the afferent arteriole and drains via the efferent arteriole. These arterioles generate the pressure within the glomerulus that help aid in filtration. The diameter of these arterioles are under control of the sympathetic nervous system as well as various hormones, and can modulate filtration rates based upon dilating or constricting. This concept is incredibly important, but it's really beyond the scope of the podcast, and it's really not part of the overview, but you'll become very, very familiar with how pressures and filtrations are affected based on size of afferent and efferent arterioles. So the capillaries of the glomerulus are lined by endothelial cells with large pores or fenestra. So in the middle here, you can kind of make out a little bit, especially on this image here, these single layer endothelial cells within the glomerulus. The pores or fenestra, as I said, allow for the free filtration of fluid, plasma, solutes, and small proteins. Above the endothelial cells sit the glomerular basement membrane. The glomerular basement membrane is composed of type 4 collagen and a lot of other proteins, chiefly heparin sulfate. These impart upon the glomerular basement membrane a negative charge overall, and it's this negative charge that repels largely negatively charged proteins such as albumin, ensuring that it isn't filtered and excreted, because the body doesn't want to waste or excrete proteins and then have to use energy to make more proteins. So just one of the ways in which that it can do this is by utilizing this negative glomerular basement membrane and the amount of heparin sulfate that's within. Finally, wrapped around the glomerular basement membrane and endothelial cells are podocyte foot processes. And this image really shows, you can see the podocyte and then all the interlinking foot processes that the podocyte gives off. These podocytes further limit the passage of molecules into Bowman space, and like the glomerular basement membrane, the podocytes are charged negatively, and this further repels negatively charged proteins like albumin. In addition to this, the size of the fenestra between the endothelial cells with the glomerular basement membrane as well as the podocyte foot processes create slits that are small enough that red blood cells can't just easily move through them. And if you see in this image, you can see the red blood cells are far too large that they wouldn't fit out of these pores. On the right of this image is a histological slide, and you can really see in here all of the tufts of capillaries that make up, the glomerulus. A good amount of pathology results from disruption of the glomerular basement membrane, the endothelial cell, and the podocyte foot processes. And I'm sure a lot of this, if you're not familiar with, it'll be covered in other podcasts, and you will definitely be familiar with it in the future in any kind of clinical lectures that you have. All right, so moving on then, a little bit more about the nephron. So once the filtered components make it into Bowman's capsule, through there they can then enter the proximal convoluted tubule. And it's in the proximal convoluted tubule that a large portion, approximately 2/3 of the filtered sodium and water are reabsorbed. And here in the proximal convoluted tubule, all organic solutes like glucose are reabsorbed. And this image on the right, it just kind of shows you very early on in the proximal convoluted tubule the great magnitude of these organic solutes that are reabsorbed and then put back into the circulation. Then we move through the descending and ascending loops of Henle, and finally to the distal and then into the collecting system. The filtrate traverse water is reabsorbed, and all organic solutes are either secreted or reabsorbed as you move through this system. So the exact mechanisms here, they're very, very complex, and again, it's beyond the scope of the things that I wanted to accomplish in this podcast. But I just want to make it aware to you that there's a lot of different things that occur in many of these different components within the nephron. And interestingly, a lot of drugs that you'll be prescribing in the future, the mechanisms of reaction rely upon affecting different components within this collecting system, chiefly the diuretics, and different diuretics work on different components, and this is something that you'll become intimately familiar with in the future. So moving on from there, I want to take a moment to talk about what I alluded to earlier, the renin-angiotensin-aldosterone system. So we talked a little bit about the arterioles and how the arterioles are able to expand or contract, and how that can affects the filtration rate at the glomerulus. So starting here on the left, we have the liver, which produces angiotensinogen. Angiotensinogen is cleaved by renin into angiotensin 1. Angiotensin 1 is then cleaved by ACE into angiotensin 2, and angiotensin 2 has a whole number of effects that you can be seen on the right here. The bottom line for all of this is the kidney is able to sense a decrease in renal perfusion. And what I mean by renal perfusion is, for whatever reason, the blood pressure has dropped. And the kidney doesn't like the blood pressure being dropped, because then it's not able to filter as efficiently as it had previously. So what the kidney then does in response to the drop in blood pressure is release renin. And the renin then is able to proceed and to create, finally, the downstream angiotensinogen 2. And eventually, the angiotensinogen 2 leads to the secretion of aldosterone. Aldosterone then has the kidney reabsorb more sodium, more chloride, and in essence, as it's reabsorbing the sodium and the chloride, it's able to retain more water, which increases the overall volume within the body and should, in effect, raise the blood pressure. Now that is really, really a very quick and dirty explanation of the renin-angiotensin-aldosterone system, and this is something that's very complicated, and there's a lot of pathology involved and a lot of different components and things that go into this. There's a lot of drugs that affect this pathway, and in my opinion, it's very interesting and something that's really worth your time to kind of delve into a little bit further. Okay, so next, as alluded to a little bit before, the kidney is also important in the regulation of calcium. And I just want to kind of draw your attention to the middle of this graph here and just make it aware that the kidney is capable of converting calcidiol into calcitriol. And calcitriol is the active form of vitamin D within the body. And it's this active form of vitamin D that allows the intestine chiefly to reabsorb more calcium as it moves through your system. And again, I talked a little bit before, kind of in the learning objectives and alluded throughout, that the kidney is important for hematopoiesis. So if we follow this nice graphic on the left, we can see that the kidney is able to sense a reduced oxygen carrying capacity. So that's a decrease in hemoglobin within the red blood cell. And in response to this reduced oxygen carrying capacity, the kidney secretes erythropoietin. Erythropoietin eventually makes it to the bone marrow, and it stimulates the developing erythrocytes within the bone marrow producing more erythrocytes and therefore increasing the oxygen carrying capacity. And finally, the increase in oxygen carrying capacity relieves that original reduction, and then the kidney is no longer going to release erythropoietin. Just an interesting aside, patients that have chronic kidney failure, when they're going for dialysis, a lot of times agents like erythropoietin can be added when they're being dialyzed because their kidneys are no longer functioning properly and secreting their own native erythropoietin, so it has to be added later on. Alright, so I know that was pretty quick, and we talked about a lot, but I just wanted to get across some of the more basic things about the kidney and the kidney function. If you have any questions or any other issues in the future, please contact me. I can be reached at edrago@tcmc.edu, and I really hope you learned something. Thanks a lot.